Thank you to all the audience who follows our broadcast. We have the honor today of having with us Dr. Nader Sanai. Dr. Sanai is J.N. Harbour Professor of Neurological Surgery and Francis and Dion Najafi Chair in Neurological Oncology, Director of the Division of Neurosurgical Oncology of the Barrow Brain Tumor Research Center, and Director of the Ivy Brain Tumor Center. Today at the 2021 IWBNC, Dr. Sanai is going to share his lecture, Building an Intraoperative Mapping Program for Gliomas. Please write your questions in the Q&A panel. We will read them after the end of Dr. Sanai's lecture. Welcome, Dr. Sanai, and thank you. The screen is all yours.
Well, thank you very much for having me, to the organizers and to the audience for making time. I've been asked to speak about building an intraoperative mapping program, which is something that's obviously a big part of my practice as a brain tumor surgeon. I think that any discussion of building a mapping program first has to begin with the rationales for having a mapping program. And really, that comes down to improving extent of resection for high and low grade glioma patients while maintaining a minimum level of neurological morbidity. So for those in the audience that are not familiar, there has been a controversy that's unfolded over the last 10 or so years regarding the timing of surgery for patients with gliomas. And in particular, that controversy has borne out in the space of low-grade gliomas. 15, 20 years ago, if a patient presented to us with a low-grade glioma, many neurosurgeons would make the argument that if the tumor was asymptomatic, that it's reasonable to watch and wait. And that was a practice that was carried on for generations until investigators started to look at the data. And here's a very rigorous study that came out of Europe, published in the Journal of the American Medical Association back in 2012. And it basically involved two parallel cohorts, two hospitals that had different practices in terms of their management of low-grade gliomas. So this group followed 153 patients and identified 47 of which who went to the hospital that managed these patients more conservatively and basically biopsied most of them, but not resected. And then a parallel group of 75 patients that were referred to a hospital that was more aggressive with their management strategy and biopsied patient, or rather resected patients rather than biopsied them. And as you followed these groups out over time, over several years from their initial surgery, one group had kind of a biopsy and watchful waiting approach, and the other group had an early resection approach. And quite clearly, there was a survival benefit for patients that were intervened on earlier. Now, this wasn't the only study that showed us that early intervention mattered. There was a subsequent study also out of Europe that looked at, again, two parallel systems that had different practices. And while these are not randomized studies, the evidence is quite overwhelming that watching and waiting a low-grade glioma, for example, even if the patient is asymptomatic, is not really supported by the data. And in fact, it represents a missed opportunity to intervene early on in a patient's pathogenesis and possibly change that. Now, for low-grade gliomas, extent of resection can be more challenging than for high-grade gliomas. And part of the reason is that these tumors typically present to us larger because they grow slowly over time and patients don't become symptomatic until they've reached a critical mass. And also because our metrics for examining extent of resection are different. For high-grade gliomas, we gauge extent of resection on the basis of contrast enhancement. And for low-grade gliomas, we gauge it on the basis of flare. So it's a different sort of set of grading systems. And it's harder to remove all the flare on a tumor than the contrast enhancement. Now, there have been many studies over the years looking at the role of extended resection for low-grade gliomas, and this is one such study out of UCSF, which I think still remains one of the pivotal studies in the field with respect to low-grade gliomas. And it told us very clearly that extended resection had a very clear impact on overall survival. Even if a subtotal resection was achieved, any patient that had more than 80% for low grades still demonstrated a survival benefit. And there have been many other studies, as I've mentioned, and here are just a few that I've highlighted, that have also validated the importance of removing as much tumor as possible. And these studies have also looked at this really critical question of a complete versus a subtotal resection and arrived at similar conclusions. Now, extended resection and getting more tumor out safely through a mapping program or any surgical technique is obviously something that many modern neurosurgeons embrace in neurosurgical oncology. But it's not just about overall survival. It's also about changing the risk of malignant transformation. Because for a low-grade glioma patient, the real danger is not necessarily tumor recurrence, but it's tumor transformation to higher grades that become more and more uncontrollable. And we know that given enough time, any WHO grade 2 glioma will ultimately become a grade 3 or 4 glioma. So how do we change this risk of transformation? Well, by cytoreducing the tumor, by decreasing the total tumor burden, that seems to have a very direct biological effect on reducing the risk of transformation. And this makes sense from a tumor biology standpoint, because by decreasing the total amount of tumor burden, we're preventing it from reaching a critical mass, we're disrupting the tumor microenvironment, and for probably other reasons that we don't fully understand, it makes it more challenging for these tumors to ultimately become higher grade. Now, most low-grade glioma patients, if they present with a symptom, present with seizures. And seizure control is a critical issue for these patients. So it's not just about survival, it's not just about malignant transformation, it's also about quality of life, especially for patients that we expect to live for many, many years. And what this data from Johan Palud shows us is that, in fact, seizure control is itself related to survival and transformation rates. And just as importantly, seizure control is modulated by how successful you and I are in the operating room with tumor reduction. The more tumor extended resection we achieve, the better seizure control there will be for these patients, and therefore the better quality of life. And in fact, there is also a thresholding effect here, where you need to arrive at around 80% or more of tumor resection in order to achieve an Ingle grade 1 status in seizure control. Now, obviously, we're talking about subtotal resections up until a total resection, but supratotal resections are also possible, more commonly in low-grade tumors than high grades. And those, in turn, also enable exquisite overall survival, although this is a very select group of patients, and we have to be very picky about who we try to achieve a supratotal in. But mapping techniques are one of the fundamental techniques to use in achieving a supratotal resection, where you're going beyond the flare margins and really just going to the nearest functional pathway that can't be sacrificed. Now, I'm describing low grades and gliomas as if they're all the same, but we know that anatomy matters. Insular gliomas, for example, are a specific subtype of tumors that are particularly challenging for us. And we see that even when we look at those gliomas in particular, whether it's progression-free survival, overall survival, or malignant progression-free survival, we see this very definite extended resection benefit associated with all of these metrics. And more recently, as we've redefined the WHO criteria in molecular terms, the question has become, how does the molecular profile of tumors impact our surgical goals? I've shown you data from hemispheric low grades, I've shown you data from insular low grades, but what about specific subtypes of low grades like 1p19q co-deleted tumors, which we think of as oligodendrogliomas? Well, the data on those tumors is a little bit more gray than black and white. In fact, even with 10-year follow-up, there is a more diminished impact on extent of resection with these slower growing tumors. And that's been demonstrated by our group here at the Barrow, but also by other groups elsewhere in the US and the world. And the basic message is that even though low-grade gliomas grow at a more indolent pace, there are still variations within that subtype. And oligodendrogliomas or 1p19q co-deleted tumors are definitely on the slower end of that range. And because they grow so slowly, we have to be even more careful about the risk of morbidity with our extent of resection, because extent of resection is not as dramatically impacting their overall performance as it would in a higher grade tumor. So this again speaks to the need for mapping techniques and other techniques that improve morbidity profiles. And here are some additional data making that same point from another group looking at low grades. And so as we look ahead to deploying mapping techniques for low grades, we know that there are certain regions of the brain that are high risk for morbidity and therefore require those types of techniques, and there are other regions that are low risk and perhaps don't. And here's one example of that type of analysis. So for low grades in particular, biopsy is preferred to watchful waiting. Complete and near complete resections are not only associated with an overall survival benefit, but they are also associated with better transformation rates. And now we need to understand the impact of surgery in the context of tumor genetics. For high-grade tumors, the story is slightly different because we're dealing with a much more aggressive variety. Now, there is no high-level, level 1 data looking at biopsy versus resection for high-grade tumors, but there is this one randomized study with a small group of patients that are over 65 years. These are grade 3 and 4 gliomas that were randomized to craniotomy versus biopsy. And the data here is pretty clear in terms of a survival benefit favoring a resection. Now, this is a small sample set with a very marginal p-value. I personally think that the best data we have is the 5-ALA study from Walter Stummer and his colleagues in Germany, where they randomized patients to 5-ALA fluorescence-guided surgery versus not. These were all glioblastomas. And even though the study was powered and designed really to look at the value of 5-ALA for extent of resection, it becomes, in effect, a surrogate study for extent of resection. And you can see that the gross total resection rate in patients who received the fluorescence was nearly double those in the control group. The 6-month progression-free survival was nearly double. And even though it wasn't powered for overall survival, when they went back and looked at overall survival, there was a nearly 6-month survival benefit with this greater extent of resection. So this really, I think, impresses upon us what many other studies are also telling us in the last 10 or 12 years, which is our roles as neurosurgeons is critical in setting the table for these patients and putting them in a good position for all of the other therapies they're going to get and to enable those therapies to work optimally. Now, one question as surgeons which relates to stimulation mapping is, obviously these techniques we use are designed to incrementally improve our extent of resection. But how much extent of resection should we be aiming for in a glioblastoma? Of course, we're all aiming for 100%, but that's not always possible. So what is the minimum that needs to be required? And what is the incremental benefit of every step above that minimum? This is a study that we did back when I was at San Francisco with Dr. Berger about 10 years ago, looking at not just complete extensive resection in newly diagnosed glioblastoma, but all of the intervals from a subtotal to complete. And what we saw very clearly was that there was a thresholding effect. And just like these other studies, in low grades, we saw about an 80%, 78% thresholding effect. If you achieved an extent of resection beyond that, there was a survival benefit, albeit marginal. And as you went higher, it became more dramatic. But if you were below that, there was no survival benefit. So today, if you or I look at a newly diagnosed patient with a suspected glioblastoma, we have to ask ourselves, volumetrically, do we think we can achieve at least 78%? If the answer is no, then this is perhaps a patient better off for biopsy and adjuvant therapy. Now, grade 3 gliomas are a little bit more difficult because they really are a mix of biologies in many cases, and it depends on how you're measuring extent of resection. But here is a study that measured it on the basis of T2 signal on the MRI. And their threshold for a survival benefit was around 50% of the T2 or flare. Speaking of molecular subtyping, as we talked about in low grades and high grades, there is also some controversy around the role of IDH1 mutants and resecting beyond the contrast enhancement. This was initially suggested out of MD Anderson, although the data so far has yet to corroborate this, so we're still trying to figure this out. But the suggestion was that if you had an IDH mutant glioblastoma, resecting the flare provided a survival benefit, and if it was IDH wild type, resecting the flare did not. Now, that data hasn't really been validated yet independently, but we have this data, which is very interesting, categorizing high-grade gliomas into what they call proliferation dominant versus diffusion dominant. Proliferation dominant tumors, it's a radiographic phenotype where the contrast enhancement represents the majority of the total flare, and diffusion dominant is where the flare is much larger than the contrast enhancement. And interestingly, in the proliferation dominant subtype, resecting the flare provides a survival benefit that's statistically significant, and in the diffusion dominant, it does not. Perhaps suggesting different biologies here, where in the proliferation dominant, the flare has very real and high levels of tumor burden, and in the diffusion dominant, the flare actually represents mostly cytotoxic edema and vasogenic edema. So for high-grade gliomas, the data is probably even more robust, suggesting that extent of resection matters, suggesting that an 80% extent of resection threshold exists for newly diagnosed glioblastoma, and there has since been data from our group at the Barrow, as well as others, confirming that for recurrent glioblastoma, that same threshold exists at 80%, and that morbidity matters in these cases. And this takes us to the technical side of extent of resection, of which brain mapping is an integral part. Improving your extent of resection is a combination of technique and technology. And the purpose of all of these techniques and technologies is to maximize the extent of resection and minimize morbidity. And it begins with the fundamentals. It begins with basic surgical techniques and approaches, using the subarachnoid planes to your advantage, designing your operative approach around a planned point of entry, positioning your patients optimally so that the anatomy unfolds itself for you with gravity, and using stimulation mapping techniques to identify functionally silent corridors to reach your target. On the technology side, as we know, there's no end to the number of technologies available in the operating room today. From fluorescence-guided surgery, which really should be considered standard of care for high-grade gliomas, to intraoperative MRIs, which we know exists for many years, intraoperative ultrasound, which is really making a resurgence with the new technologies that exist, intraoperative CT, which is also becoming more popular. So let's look at some of the basics of arachnoidal dissection and how that helps us get around the morbidities of surgical resection. So here is an insular type glioma within the insula. Obviously, insular gliomas can be approached through a variety of ways, but one such approach is a transsylvian approach. And a transsylvian approach gives you several advantages over a transcortical. One is that it avoids going through any cortex, so obviously there's some decreased morbidity there. The second is that it gives you access to both the temporal and the frontal side of the insula, really through a single approach. And then finally, for patients that have pure insular lesions, it preserves the subcortical regions of the temporal and frontal lobes, which is important. In a patient like this, for example, with a dominant hemisphere insular glioma, not having to go through frontal or temporal lobe is important. Now, transsylvian approaches are not the only way to get to the insula, and in fact, in our experience and others, there are certain zones of the insula that really lend themselves to a transcortical approach. And that's because as you're trying to get up posteriorly and especially superiorly in the insula, you have to really split that fissure very, very wide and pull up on the fissure to get to those regions, and that's where some of the morbidity occurs. Now, selecting the entry point for a brain tumor, and here you see a WHO grade 1 JPA in a young adult. This JPA is located in the pulvinar of the thalamus, and reaching the pulvinar of the thalamus can be tricky, except if you take a lateral supracerebellar approach, as we've done here. Then it's very straightforward, because the first point of entry is really the peel margin of the pulvinar. You're not going through anything else to reach it. So here we've come above the tentor or below the tentorium, above the cerebellum. We've cut the tent. We've gone above the trochlear nerve and then used navigation to get to this lesion. And obviously with a grade 1 JPA, extent of resection matters because it's curative if we get a complete resection. Positioning patients is especially important when it comes to deep-seated regions. So here we have a thalamic glioma, and we're coming interhemispheric. We have the patient positioned in a lateral position with the neck laterally flexed away from the floor. And so we have this horizontal view, which is good for our eyes and good for our hands. And we're coming down with one hemisphere dropped down, and you don't see any retractors in here. There's really no need because you just have natural arachnoidal dissection, allowing that hemisphere to pull away. We're using lighted instruments to get down into the ventricle, through the callosum into the ventricle, and we see the bulge in the wall of the ventricle, which is the tumor itself, and we enter that directly without going through any other regions. Now, obviously, thalamic gliomas can carry significant morbidity, so patient selection is critical for these cases, but it is appropriate to resect these tumors under certain circumstances, and you can get excellent radiographic results as well as clinical results in these patients. Of course, we're going to spend more time talking about building a mapping program, and part of that involves identifying non-functional corridors. Sometimes, for tumors, all of the eloquence is around the tumor, and therefore you can basically go en bloc. Sometimes for tumors, there are pockets of eloquence scattered above the tumor, and you have to create these windows that take you down deep into the subcortical white matter and perhaps preserve islands of functionality. So whether you're taking an en bloc or a windowing approach, the key is to understand where the functional pathways are. Fluorescence-guided surgery, as I mentioned, really should become a standard adjunct for high-grade gliomas. It's obviously uses the drug 5-ALA, which is approved for use in the US for glioblastoma and also approved in the US and in Europe and other countries. We and others have also been looking at deploying 5-ALA in low-grade tumors. 5-ALA is metabolized to protoporphyrin 9 in low-grade tumors, and it does create fluorescence, but the fluorescence is too low in intensity to visualize with a light microscope and with your eyes, which is why we have these handheld devices in development that give you not only a qualitative visualization of the fluorescence in a low grade, but even a quantitative heat map. We've talked about other technologies that are in some of our operating rooms. This includes intraoperative MRI, which, as we know, is a very costly technology that adds a lot of time, but certainly has been proven in its value, not only in terms of cases with brain shift, but also in terms of just simply improving extent of resection, as this study showed nearly 10 years ago, and demonstrating that the extent of resection was associated with better overall survival, as we know. Now, a lower cost and more versatile device in the operating room is the intraoperative ultrasound. And the technology here has really accelerated. So here you have a low-grade glioma where you are in the process of resecting the tumor. And you want to know where the lenticular striates are. Now, stimulation mapping can tell you where the internal capsule is as you get down near it. But visualization of these vessels is not something easily done in the operating room. Typically, if you're seeing the vessels with your eyes in the operating room, it might be too late and you've already incurred some injury. So intraoperative ultrasound can tell you when you're getting close to these lenticular striates in real time without a lot of additional time added to the case. And it's cost efficient as well. Another cost efficient technology is intraoperative Ct. Now, obviously, this is not giving you the type of resolution or detail that an MRI gives you, but for certain tumors, high or low grade tumors that have calcifications, high grade tumors that enhance, it can give you a broad strokes analysis of where you stand in terms of the extent of resection. So for glioma extent of resection in general, we're talking about early intervention. We're talking about changing the natural history of these tumors by impacting its transformation rates. We're talking about achieving a minimum 80% low or high grade, but especially high grade volumetrically, and we've touched on some of the techniques. So let's try to find our way towards this concept of stimulation mapping. Here's a patient who presents with a larger insular lesion, likely a high-grade glioma. He's 74. He presents with some hemiparesis and word-finding difficulties. Now, there are many management options here, and I don't think any of these are necessarily wrong, although the data doesn't support all of them equally. And in fact, I would say that you have to resect a patient like this if they're in good enough clinical health. And how you resect it depends upon where the surgeon is comfortable doing what. So here, for the insula, there are two general paradigms. There's a transcortical and a transsylvian approach. Not many groups have looked at how these things compare, but it is important to give credit where credit is due to Johann Schramm, who many years ago looked at his medial basal experience, which included insular gliomas, and really made the point that for transsylvian tumors, there was a morbidity rate associated with the vascular injury that is incurred in the transsylvian approach. Now, when you're looking at insular gliomas, it's important to understand the anatomy. The reason these tumors are amongst the most challenging tumors you can resect is because of the complex anatomy and its deep-seated nature. We divide insular gliomas into 4 zones. Those zones are divided by a plane through the foramen of Monro and a plane through the Sylvian fissure. And each zone itself lends itself to certain surgical exposures. So for example, an anterior superior located insular glioma is much more amenable to a Sylvian fissure split than something more posteriorly. So here we have 2 tumors in similar locations representing these 2 paradigms, and this is our institutional experience with these low-grade glioma, or sorry, with these insular gliomas. And in one case, we've taken a here we go. In one case, we've taken a transsylvian approach, and in one case, we've taken a transcortical approach. And in both cases, you can achieve successful extent of resection. And the point here is that there is no wrong approach when it comes to every glioma patient. It has to do with your personal comfort as well as some of the nuances of the case. In our institutional experience, when we looked at 100 patients that had, the last 100 patients that had an insular glioma resection, it was divided fairly equally between transsylvian and transcortical approaches. And the outcome was fairly similar between these approaches. And of course, the transcortical patients required stimulation mapping, and in many cases, even the transsylvians did it as well. But there were certain histologies as well as certain zones that lent themselves to certain approaches, and in particular, those posterior superior zoned gliomas where you really had to achieve a very high degree of surgical freedom in order to achieve it. So here we have that initial case example that I showed you. This is a patient where we ultimately opted to go transsylvian. Now in this case, this is a relatively pure insular glioma occupying all of the zones. This is a tumor that's abutting the medial structures, especially the internal capsule and the lenticulostriates being pushed medially, which happens about 85% of the time. So as we got into the fissure and started to resect this tumor, we started to define the borders not only anatomically, as you see here, but using the ultrasonic aspirator coming more medially, we're going to be approaching that internal capsule. And that's a real excellent opportunity to deploy subcortical stimulation mapping so that you identify that medial margin as easily as possible and so that you're not charging more medial than you expect. Because using navigation or even using your eyes to identify where the medial border of the tumor is not a reliable exercise in these tumors, especially as the case goes on and you have brain shift, so the navigation is less reliable. And as the case goes on, the qualitative feel of the tumor in normal versus abnormal becomes blurred. So that is never a good way to rely upon extent of resection. Now, you can see here, as we come more medial, we're going to deploy the stimulation mapping protocol, and we're going to resect, map, resect, map, resect, map, until we get down to that descending cortical spinal tract. And when we think that we're getting close, we're going to deploy the stimulation mapping. We don't need high thresholds here. Subcortical thresholds are always lower than cortical thresholds. And you see we get a little arm motor stimulation there, which tells us that we're really done at that point in terms of pushing that margin. And so ultimately this achieves what you want radiographically, what you want functionally. And the point is that the surgical approach can be tailored, but identifying the functional pathways is a common denominator for these patients. And that's what you have to worry about in terms of morbidity. Morbidity from vascular injury, but also morbidity from transection of subcortical pathways. And this takes us to kind of a summary statement on why a mapping program is essential for any brain tumor surgeon doing intrinsic tumors. And this meta-analysis from Philip DeWitt and colleagues really makes the point that number one, a mapping program reduces the incidence of long-term morbidity, and number two, it improves extent of resection. Now, within the pantheon of mapping programs, there are two that really rise above the others, in my opinion, which is the San Francisco program led by Dr. Berger and the Montpellier program led by Dr. Dufault. And what's interesting about these two gold standard programs, which I believe are really important aspirations for all of us to achieve, is that they achieve their results with fairly different protocols and practices. When it comes to neuroanesthesia, they have different practices at each center. This includes intubating versus not intubating the patient. It includes having the patient asleep for some of the mapping or having the patient awake during resection. The habits are different, even though at each center there is a tailoring of the case. The programs differ in these qualities. They also differ in terms of their utilization of technology, whether it is preoperative imaging, intraoperative navigation, the use of intraoperative microscopy, the use of intraoperative electrocorticography. It is really interesting that they both achieve excellent results with, in some cases, diametrically opposite practices, which speaks to the strength of the surgeons and also the strength of the protocols that the surgeons have developed. In San Francisco versus Montpellier, there are different patient selection criteria. There are different intraoperative mapping sequences. There's a differential emphasis on negative versus positive mapping, and there's a differential reliance on asleep motor mapping. But what is not different between the two are the results that they have reported, which are uniformly excellent. And really, in my mind, these are the types of numbers that any program should aspire to achieve. Seizure rates is one of the best sort of barometers of our neuroanesthesia partnership. And you can see here how exceptional the seizure rates are for both groups. And the long-term deficits are obviously an exceptional barometer of the surgical technique and success at the program. So when it comes to building a mapping program, it really comes down to four fundamental building blocks: neuroanesthesia, your selection of cases, the protocol that you employ for the entire operating room, and the technologies that you might have available to you. The program cannot get off the ground without good partnership with neuroanesthesia. This is our neuroanesthesia regimen for most cases at the Barrow. And I arrived at the Barrow 10 years ago, and at that time there was no mapping program here. Intraoperative mapping was not done. It was not seen by anyone here, and we had to build it from the ground up, brick by brick. Here you see these pie charts over the last 5 years in our mapping program, and each slice of the pie is a different neuroanesthesiologist in our group, and the number represents the number of cases they did that year. And you can see that over time, we've started to specialize our neuroanesthesiologists, decreasing the total number who do our mapping cases and increasing their denominator of cases so that their experience makes them expert. And the best way to really understand this improvement is to look at our intraoperative seizure rates. And what you see here are focal motor seizures and generalized seizures. Focal motor in green, generalized in red or in orange over the last 5 years, coming down steadily. We're not at zero, but we've reduced our reliance on intraoperative electrocorticography from 13% of cases 5 years ago to almost non-existent today. And we've reduced our intraoperative seizure rates. This is because of our partnership with neuroanesthesia. The other trend that is, I think, emblematic of a successful mapping program is more conservative case selection. As you become more aware of the limitations of mapping, you become more selective in who goes through it. This means, in our case, using a sleep motor mapping instead of awake for cases where patients are very large, where there are neuropsychiatric or language-related deficits or significant mass effect. And a sleep mapping for motor versus awake mapping clearly sacrifices something, as this study showed almost 15, 17 years ago. When you're asleep with general anesthesia, the stimulation thresholds you need to use are higher in order to drive the pathways, which can increase the risk of intraoperative seizures. So you have to balance that risk against the benefit of avoiding an awake case in a patient that might not do well in that circumstance. So you can see over the last 5 years in our program, our proportions of asleep versus awake mapping have started to level out, and we are more judiciously using awake mapping in cases where we really feel like the asleep motor mapping is insufficient. And obviously, most of our awake mapping cases today really are focusing on language and less so on pure motor. One of the first things I did when I arrived at the Barrow was to write down a very rigorous protocol for how we would map these patients. This was something that I distributed to all of our nurses, all of our anesthesiologists, all of our residents, and I took it step by step in terms of what would happen when, how long it would take, and what patient's condition would be at that time. This lets people know in your operating room what to expect so that you're not the only person that can see how things will unfold. One of the most important elements of a mapping case is developing paradigms that are rigorous and consistent in terms of positioning. So here we have a patient positioned in a semilateral position. You want to keep their shoulders and their hips all in parallel with their head. You don't want a lot of head turn. You don't want a lot of neck flexion. If you're using navigation, you want to keep that arm away from the patient's body in case if they move, they don't bump it. We use a Layla bar in order to keep the drapes off the patient's face. We make sure that the patient's arm is unencumbered, that that arm is padded. Ideally, we don't have any IVs in the patient's arm that's being mapped, and their neck is slightly extended. And in this case, we have an LMA in the patient. The LMA will come out for the mapping and then go back in. The reason for the neck extension a little bit is so that if there needs to be an emergency intubation, it makes it easy for the anesthesiologist to do that in the lateral position. And our positioning for asleep motor mapping is the same as it is for awake mapping. This simplifies things for the operating room. Everyone in your operating room needs to know their roles, and you as a neurosurgeon need to know their roles too. From the scrub techs to the circulators to the anesthesia techs to the anesthesiologist. We have neuromonitoring folks in our operating rooms for EMG monitoring in asleep cases. We have an intraoperative neuropsychologist and speech therapist that takes us through the mapping paradigms with the patient. We have some technology developed. This is a mobile unit that demonstrates to the patient on a laptop screen the actual paradigms we're testing. It has a camera that enables me to see the patient's face and a mobile microphone that enables me to hear the patient's voice, because as a surgeon, I need to understand the subtleties of their feedback, not just whether they answered the question right, but did they hesitate? Was there any disturbances to their language that I can detect? And in cases where it's appropriate, we use intraoperative electrocorticography. So understanding that technology and being able to read the ECOG screen yourself is important. In our cases, the general sequence of events begins with the patient being positioned while they're awake. Then they get pinned. Sometimes they're awake for this, but oftentimes they're asleep. We then register the patient to our neuronavigation while they're asleep. We put the anesthetic in along the marked incision, perform the craniotomy while they're asleep. We open and expose the dura, but we keep the dura closed while they're asleep. And we put local anesthetic into the dura along the middle meningeals. Then we wake the patient up and allow the patient to hyperventilate, to relax the brain, blow off CO2, and that's when we open the dura. At that point, if there's cortical mapping, that's when it's undertaken. There's tumor resection, which is often done while the patient is asleep, and if they need to wake up for more subcortical mapping, that's what happens. And then we go on to completion of the resection while they're asleep. There are many technologies that can be helpful. We've talked about some of these already. A functional MRI is not something you can use to guide surgical resection. It does not have that level of specificity. It can tell you which hemisphere is dominant. It can give you a general sense of how close you might be to some general functional pathways, but it does not replace stimulation mapping, and the same is true for tractography. Tractography has higher specificity than fMRI, but it still has too much variation at the millimetric level to make surgical decisions. So you should never make surgical extended resection decisions on the basis of tractography, because if any of you have actually performed the tractography analysis yourself, you know that it is highly variable in terms of where those tracks start and stop, and it is non-scientific in that respect. You can't make clinical decisions on the basis of that, but it is a good guideline for planning your extended resection. I mentioned some of the audiovisual integration that we use, and this is critical in terms of visualizing the patient as you're mapping. And there are always study devices like this intraoperative device that measures blood flow to functional territories and quantifies it as a surrogate for sensory cortical mapping. To give you an example of the limitations of tractography, here is a mesial temporal lesion within the frontal lobe. Tractography suggests that there's the tracts that are pushed laterally. We take an interhemispheric approach here. Remember, one side down to allow for gravity retraction, a simple linear incision, a craniotomy crossing the sinus. We then cut the falx. There's no retractors required here. It's just simple visualization and arachnoidal dissection. Cutting the falx is very simple in these cases. This is not a difficult technique. You just simply create a trap door. If you're right-handed, it means you cut from right to left, come down, push that trap door down. Now you're looking at the mesial cortex. Stimulation mapping is undertaken, and in fact, despite what the tracks tell us, there is functional cortex on that medial aspect of the tumor. Inferiorly, but superiorly, there's a non-functional corridor, and that's what we resect. We come through that corridor, again, using lighted instruments to visualize things deep down. Once the tumor is resected, we then map on the back side of the tumor. Now we're up against the tracks that you can see on intraoperative navigation and on the preoperative tractography. And once you visualize those tracks, you can stop your extent of resection there. And at that point, you've achieved what you need to achieve in this patient. So stimulation mapping programs are really a long-term investment. No one is going to begin a program and have immediate success. This is our data for the last 10 years, looking at about 600 or so patients that have undergone mapping at our center, starting from a program that was built from the ground up. You can see that our metrics are nowhere close to what's been reported at San Francisco or Montpellier, but that's because those programs have been in development for 20, 30 years. And that is where the learning curve exists for this type of program. You can see that over time, we've gone down from 11% deficit rates transiently to 7%, and even in the last 5 years improved from an intraoperative seizure rate of 7% to 3%, but this is not zero. And this learning curve continues for our center, and it will for yours. So building an intraoperative mapping program clearly can improve morbidity in patients with eloquent tumors, but it is a multidisciplinary partnership. It requires you not only to develop relationships that are strong and bidirectional with everyone on your operating room team, but it requires you to think about when you're deploying this technique, how you're deploying the technique, what technologies you're using, and to get everybody at your program ready for the learning curve, because things will not start off smoothly, and it will require you to constantly refine your approach until we reach this sub 2% seizure and morbidity gold standard that San Francisco and Montpellier have set for us. So with that, I will thank you again for the invitation at this important meeting. Thank you to the audience and the organizers, and I'm happy to take any questions or field them by email in the future.
On behalf of CN and the IWBNC, I'd like to thank you again, Dr. Sanai. It has been a very, very enlightening lecture. We are really grateful and honored for your participation. I have a few questions from the audience that you may answer. First is Dr. Harshad Patel asks a question in relation with thalamic tumor resection. What strategies do you recommend to avoid venous infarcts during tumor resection? And do you think navigation helps you in preventing this kind of complications?
So for thalamic tumors, there are several ways to get there. It depends on the location of it within the thalamus, what hemisphere it's in, and how it relates to the atrium. So for example, for a right-sided thalamic tumor that's extending back towards the atrium, you can take a parietal occipital approach, which is a very safe approach, taking it through the ventricle into the thalamus, and that can be done very safely. You typically map subcortically on the front end of that tumor. For dominant hemisphere lesions or for lesions that are closer to midline, an interhemispheric approach is appropriate, and we do those in a lateral position. Now, the risk of venous infarct, I think, is very low, and the reason for that is because you can use navigation to identify where the bridging veins are. And you don't need a big window in order to get down interhemispheric. It really just needs to be a centimeter or two between the two nearest veins. So we position them laterally, we use the navigation to identify where the bridging veins are, we identify a window between two bridging veins that's wide enough, and we make a linear incision right between those two. Once we get down there, we only open the dura within that space, and we make sure that we cover the sagittal sinus in addition to the dura itself with moist cloth so that the heat of the microscope doesn't dry out the veins and cause venous stasis. And with that approach, we really hadn't had any venous infarct problems.
Great, thank you. A second question is with respect to deep brain stimulation during surgical resection of deep-seated tumors. What do you prefer with respect to bipolar or monopolar stimulation? And what are your preferred thresholds for millivoltage?
So bipolar versus monopolar, I feel like is more a matter of personal preference. There's advantages to each. Bipolar is a little bit more specific in terms of the localization of the stimulation. Monopolar can give you a little bit more of a probing effect. We use the bipolar. It's really a matter of institutional preference. It's what I was trained with in San Francisco with Dr. Berger. So we use an Ogerman stimulator. For awake mapping cases, we start at 1.5 milliamps per channel, 60 hertz frequency, and move upwards. But really for a properly prepared awake patient, you don't need to go above 2 milliamps in my experience. For sleep cortical mapping, it usually goes all the way up from 2 milliamps to maybe 6 milliamps per channel. Subcortically, it's always less than that threshold. So I believe the right thing to do is just start low in every case, go up in half milliamp increments until you get positive results.
Great, thank you. We have another question related with stimulation. Dr. Ramirez asks, given the similar results between asleep and awake patients during resection, what are your peculiarities, or how do you decide when you do stimulation in an awake patient versus a sleep patient?
So awake for asleep in our experience has to do with two things. Language function, of course, can dictate that. So if the patient has a dominant hemisphere lesion that's close to some of these language pathways, then I believe they need to be awake in order to preserve that. Um, Awake motor is something we only use in cases where you have a lesion that's very clearly within the motor in the primary motor cortex. If it's clearly within the primary motor cortex, then you really need millimetric sensitivity to your mapping results. And the way to do that is without any anesthesia in an awake case. Outside of that, though, if we're worried about motor cortex that's adjacent to but not within the tumor, or if we're worried about subcortical pathways that are again adjacent to the tumor, we do those asleep. And obviously, it's a lot simpler.
Thank you. Dr. Andraus asks, with relationship to the planned resection in tumors related to language sensitive areas, in surgical planning, how do you plan the margin of resection? And how much do you go towards that margin with respect to low-grade and high-grade tumors?
So the margins of resection in my mind are really dictated by two things, which is the MRI and the functional pathways. In some cases, it's very clear the functional pathways are very far away, and therefore you're effectively just using MR guidance preoperatively or navigation to achieve a resection. In a high-grade glioma, that begins with going for the enhancement, but it can include resecting the flare if it feels to be safe. In a low-grade glioma, obviously it's the flare. Now, within more eloquent tumors, then that margin really has to be dictated by the functionality of it. So, for example, yesterday I did a giant insular glioma. The functional pathways there medially are what dictated the extent of resection. And once I achieved some positive stimulation on the descending cortical spinal tracts, I can't go any more medially. So that's my medial margin of extent of resection.
Dr. Benavides asks, what is your approach with respect of butterfly gliomas, especially high grade?
So butterfly gliomas, obviously are notorious, and many people just categorize them all as inoperable. I don't think that's the case. It depends on the nature of the butterfly glioma. Where is it? Is it more anterior, which can be more resectable, or posterior? Resecting a butterfly glioma through the splenium is actually fairly well tolerated too. A lot of it depends upon whether it's truly symmetrical or whether there's some asymmetry. We've all seen frontal lobe gliomas that are primarily located in one lobe but cross the corpus callosum either through the rostrum or more posteriorly, if they're kind of a parietal tumor, through the splenium into the other hemisphere. Now, technically, those are butterfly, but it doesn't mean that they're inoperable. You can chase these tumors across the corpus callosum with very good results, especially if you preserve the fornices. So we take them one case at a time. Obviously, the patient's clinical condition matters as well, but I don't consider them to be inoperable. You just have to be very selective and pick and choose your battles.
Thank you. Next question is, do you have any specific tips about tumors that are located in the supplementary motor area?
Well, SMA area tumors, I think, begin with a good conversation with the patient. You need to let them understand that an SMA syndrome is possible, and you need to give them an understanding of what that syndrome will look like. If it's dominant hemisphere, it's going to include language, for example, versus non-dominant. So first is expectation management. But beyond that, we don't consider SMAs to be inoperable. In fact, it's a very resectable region because every patient with an SMA syndrome recovers. If they didn't recover, then it's not an SMA syndrome. It's not a pure SMA resection. So I think it just comes with the surgeon identifying that this can lead to some consequences. Remember that not every patient's SMA is organized similarly. I know that there have been efforts to predict which patients will develop an SMA syndrome or not based on the anatomy, but that's an imprecise science because it's really the circuitry of the SMA that matters from patient to patient, and some patients have bilateral representation, Some patients have more unilateral representation. It's difficult to map this out with fMRI. So you just have to be prepared for the worst, which is an SMA syndrome that will last a few months, but obviously hope for the best.
Thank you. Dr. Sensai Yeo asks, what are your thoughts of using Michael Serger's very detailed connectomics to select approaches and avoid violating important networks in the brain and in the intraaxial brain surgery?
Yeah, I think that the science of connectomics is in its infancy. And I don't think that there's any technologies today that can reliably predict either deficits or functional pathways just strictly based upon imaging or connectomic paradigms. So it's an interesting concept. I think that there are many, many years to go before it can be reliably implemented in clinical paradigms, and it certainly shouldn't be used as a surrogate for anything we described today.
Thank you. Dr. Keyatel asks, for patients who cannot tolerate the duration of awake time in surgery for whatever reason, what is your protocol do in those cases?
So in our experience, it's better not to keep them awake very long. That's why we keep them asleep for the resection and other parts of the case. So we aim to have our patients awake for about 15 minutes. Okay. For most mapping paradigms, you can get the information you need in 15 minutes. Remember that for most tumors, most of the borders of the tumor are actually not against functional pathways. Usually it's one or two borders of the tumor that are critical. So you expose the tumor, you identify what border that is, you map that border while they're awake. In some cases, you map and resect down that corridor. And then when you're done, we let them go to sleep. So this really limits the amount of time that they need to be awake. Now, for some patients, they can't tolerate any time awake. And in those cases, you have to make do with what you can do while they're asleep. You also have to adjust your surgical goals, because if they can't be awake, but this is clearly a dominant hemisphere frontal opercular lesion, then maybe you have to be very conservative with your resection because you can't be aggressive without the stimulation data.
Thank you. Another question is, with respect to lesions located in the functional areas of the occipital lobe, which can be quite sometimes difficult to evaluate, and since the surgical position is going to be a little bit different, what are your recommendations with respect to the mapping, evaluation, and surgical positioning?
So I did an occipital lobe awake mapping case yesterday. It was awake because the tumor was large enough that it was approaching some of those subcortical pathways that are adjacent to the dominant hemisphere atrium, which is a very sensitive location. Positioning is the same. Positioning has to be the same for every case in a mapping program. So even though it's uncomfortable to be working all the way on the back of someone's head when they're positioned in a semilateral position, you just have to adjust yourself to that discomfort. But the patient is in a neutral position on their side, and there's just a very posterior incision. With respect to the mapping paradigms outside of language, the most common stimulation mapping paradigm for those tumors is visual pathways. We don't use that paradigm so often for a couple reasons. One is that for many of these patients, those pathways are already disrupted. The second is that for many of these patients, we expect to disrupt those pathways as part of our resection. So we discuss that with the patient in advance and make sure everybody has a similar expectation of having a field cut after surgery. Because for some of these tumors, including the one I did yesterday, there's no way to achieve an acceptable extent of resection without sacrificing a field cut. So you can choose one or the other, but you can't have it both ways.
Thank you. Those are the questions for the moment. So I'd like to thank you again on behalf of the IWNC and CN Neurosurgery. This has been a very enlightening talk, and your questions have been very great for us. And thank you, and thank all the audience for being with us for this talk. In a few minutes, we will have Dr. Lawton doing his lecture, Brainstem Cavernous Malformation Surgery. To get this link for the upcoming conference, please follow the link in the chat screen or check the program schedule on your website, cnus.com. Thank you.